Okay, everybody missed all that intro kind of thing, integrity-wise, but now I got it. We're good. One thing that's changing surgery a lot also is insurance, third-party payers. Used to, when I first started working, well, and even after I'd been working for a while and I was a head nurse of a med-surg unit, we had a lot of post-op patients. We had one doctor who they would do abdominal hysterectomies, and the patient stayed in the hospital for 10 days. Nobody went home before 10 days. At the end of those 10 days, they're walking up and down the halls. Would you pass this tray for me? They're helping us out because they're well. They're ready to go home. Third-party payers has changed that. Nobody stays in the hospital that long anymore. If they're with a walking well, we can get them out. We can't afford to have people in that long. It was really nice for the nurses because you had one really sick person and 7 people who you didn't really have to do too much. You take their temperature in the morning and let me know if you need something. And that was about it. Acuities have changed. Okay, if integrity is on, this will not go. No, we can't click it down. Let's see. What did you do?
It just you need to click back on PowerPoint because you turned on paper.
Cool. Yes, I need technocrats. That's for sure. Okay. The pre-op time period is whenever the client decides they are going to have surgery. They may decide a year in advance that they're going to have surgery. They're still in that preoperative period. It's not just when they're admitted to the hospital into that PACU unit, or pre-op short stay unit. It's very, very long term. It can be. Whenever they decide that they're going to have surgery. Until they're moved into the operating suite. Okay? That's the pre-op period. Nurses' major role during this part is education. That's why it is underlined. But we also need to see their safety and make sure that they're kept safe during that time period, because we might be giving them, in the immediate pre-op time period, we might be giving them medications that are going to limit their ability to care for themselves or to keep themselves safe. We categorize surgery by its purpose and by what's happening with it. What's the reason that they're having surgery? If, for example, they have a type of tumor, a cancer, that is so aggressive and so large that they cannot remove it, they may do a type of surgery to make their quality of life better. That's a palliative type of surgery. If you have someone who was in a car accident and they had some facial scarring, they may go into surgery to have that scar repaired or some work done to improve the look of their face. That could be cosmetic surgery. There could be restorative surgery. Maybe in that same accident they had a broken limb that got reset wrong because of whatever reason. A lot of these folks that are down in Haiti right now who have suffered major injuries because of the earthquake, their bodies have started healing before they have gotten to get care. So their surgery might be restorative. The surgeons might need to actually cause injury to improve their outcome. Okay? You can look at it in terms of diagnosis, whether it's going to be curative. A lot of times you can go into the OR and you can have surgery and it will cure you from whatever it was that ailed you. Okay? You can think of the case of colon cancer that's diagnosed very, very early on. They can go in and they can cut out that section of bowel, stitch it back together, and the person can go on and be cured of their cancer. Okay? So you can look at it in those terms. You can also look at it in terms of how urgent, how urgent it is. Do they have time to decide when they want to do it? It's elective. They elect when they want to have it. Or were they in a car accident and their life is threatened by whatever this injury is and they've got to go to the OR right now? That's emergent or urgent. Okay? How severe is it? Is it minor surgery? Is it major surgery? What's the anatomic location? That'll also come into play when you're looking at categories of surgery. And they have different names for surgery. Anybody know what a blepharoplasty is? Yeah, how'd you know that? Aha. Aha. Is a blepharoplasty always done for cosmetic purposes? No. Oftentimes it's done for a problem called ptosis, yes. Very good. Ptosis is where the eyelid droops. I should have asked you that. You could have said it. Ptosis is when the eyelid droops, and very often they'll do a blepharoplasty, which is when they will take that excess tissue out. They're not really raising the eyelids, or the eyebrows, but they're removing this excess tissue so that the eye can open up more normally again. Okay? It's a cosmetic surgery, and it's usually elective, and it's usually minor. Okay? And it's usually pretty simple because it's not very extensive. If you have someone who has a very advanced breast cancer, and they're going to take off not only that little tumor area, but the entire breast, and the muscle underlying that breast, because the tumor has infiltrated, has spread down into that muscle area. And they're also going to take out the lymph nodes that are connected, that drain that area. That's pretty in-depth surgery. That's radical surgery because we're doing so much more. You see how all these names tie together to give you a little more idea about what surgery is being done? Can you guys hear me back there okay, or do I need to speak up more? You can hear me okay? Okay. We also look at the setting where the surgery is done. We can have inpatient surgery where the client is admitted to the hospital a day or so before. It could also be they're admitted that morning. They come in, but after surgery they don't go home. They stay for a day or so. Can be longer. Outpatient surgery we call also ambulatory surgery. You'll also hear it called same-day surgery. They come in the morning into oftentimes a freestanding operating room area. They're admitted to just that area for that time period. They do their perioperative or preoperative paperwork, work up, all the stuff is right there. Then they go into the operating suite. They go into the PACU, which we used to call recovery room and is now the post-anesthesia care unit. And then from that, when they're fully awake and they can pass gas and pee and do all these things that we want them to do, we send them on alone. Okay? It's usually not a major type surgery that they're going to be doing outpatient. Okay? And this has gotten to be the majority of cases. We don't always have to put someone into the hospital. They can take care of their needs at home. Who's had outpatient surgery? Yeah. Who had inpatient? You had to stay. Loads of fun being in the hospital, isn't it? Okay, let's see. Things that you need to think of. Before the client goes in, they have to do a thorough assessment. And more than one person is doing this assessment, is collecting this data. That's why we call it collaborative, because more than one person is doing it. You're going to have the anesthesiologist that's going to be involved, or the nurse anesthetist. It could be a nurse anesthetist that's doing it. You'll have the physician. You'll have the lab drawing some of the blood work and doing all of those type of things to help get all this information that we need. We need to know how old the client is, what's their age, because the older the client is, the higher the risk of complications. My dad just turned 96. There's no way anybody is ever going to operate on him because of his age, unless it was an emergency situation. He's not a good surgical risk because of his age. He's fairly healthy. He's got a pre-leukemic condition, but other than that, he's pretty healthy, pretty happy. But he's old. The older you get, the less your immune system functions. He's very much at risk for infections of any type. If we put the stress of surgery on an older person, we're going to put them even more at risk, because stress depresses the immune system. Okay? So older clients have a poor immune response. They don't heal as quickly. It takes them longer for their wounds to heal. They have more chronic illnesses. They're more at risk with hypertension. They're more at risk with coronary artery disease. Their renal function is not as good. So they are just more at risk in general. If they use tobacco, whether it be inhalation, smoking, whether it be smokeless tobacco, in their, chewing tobacco, whatnot, they are more at risk. Smokers are going to have more problems with their lungs if they were to have a general anesthetic. These are all things that we need to take into account when we're doing the assessment. If they use alcohol, and I'm not saying they're alcoholics, if they drink alcohol every day on a routine basis, if you put them in the hospital for a length of time and they're not getting that routine alcohol, they might have some problems. We need to know about it. Any illicit drugs, over-the-counter or prescription medications, those could cause problems too. If a client, okay, most of you guys are young, who takes aspirin every day? We're at risk if we go to surgery right away. Why? Because we bleed. It takes a long time for us to stop bleeding. You have to put a lot of pressure because of the side effect of the aspirin. Same thing if someone has arthritis and they're taking non-steroidal anti-inflammatories, ibuprofen or Advil. This is going to increase their bleeding time. We need to know about that. The doctor doesn't want to go in and cut through their abdominal muscles and shoo, here comes all the blood, and they can't stop the bleeding, and they keep trying and putting pressure. You need to know about it so you can do something to prevent complications. That's the purpose of all of this assessment data that we're gathering. We want to prevent complications. Okay? Medical history. Are they pregnant? What's the likelihood that they could be? This could play into it. Any prior cardiac history? Did they have an MI recently? They're going to be more at risk. What's their pulmonary history? I mentioned smoking. They're going to be more at risk for atelectasis. Do you know this word? Whoops, come back. You guys are so good. Yes, it's collapsed alveoli. Okay, atelectasis. It's a real problem in the post-op period. I can guarantee you, almost 100%, if I've got a client in the immediate post-op area and they're spiking a temperature, it's not because they've got an infection, it's because they've got atelectasis. What do you need to do? Give them Tylenol, call the doctor? Breathe. Have them deep breathe and cough. That's going to solve that little problem right there. But that little problem right there, if we don't solve it, can go into pneumonia, an even greater complication.
Why do you run fever because of that?
The atelectasis, I'm not really sure what the pathophysiological thing is there that would cause it. But that's what you see first. It's sort of the inflammatory process causing it, I believe. Have they had any previous surgery? And when they had that previous surgery, did they have any reactions to anesthesia? Anesthesiologists really don't like to have someone who's had problems before. One of the really bad things that they need to know about is malignant hyperthermia, and this will come up later on in the slide when we talk about the intraoperative period. There are some people who are genetically at risk for this, and they want to find out about the family history. It puts the person really at risk. Can they take blood donations? Or if they have a problem, can they have blood transfusions? Or do they have some religious things that will prevent it? Or cultural. There could be some other things that would go into it. Have they given donations before? If they're going to have some sort of massive major surgery, maybe if it's elective, they can go ahead of time and donate blood to themselves. Okay? They can have blood taken off, and it can be saved in the blood bank for a period of time and can be reinfused into them post-operatively as they need it. There's different things that they call bloodless surgery. They're not really bloodless surgery, but they're ways that they try to decrease the amount of blood loss. I believe this, I did not build this PowerPoint myself, so I believe this is talking about giving someone erythropoietin before surgery. When you see EPO, that's usually what it means. Erythropoietin is what? Comes from the kidneys, and it stimulates red blood cell production. That's exactly right. Okay? It's one of your body's natural hormones. We found in doing research for chemotherapy clients, trying to keep them on their chemotherapies, they've developed erythropoietin. It's from the stem cell research. Okay? So that we can get their body to make more red blood cells before they even go to surgery. What are the discharge plans after surgery? How are they going to go home? Do you think someone who's just had surgery is going to be able to jump behind the wheel of their car and drive home safely? I don't want to be behind them. I don't want to be in front of them. They could plow into me. Okay? So they have to have someone that can take them home. So what are their plans? What's their rehab going to be? What rehab is going to be necessary for them? Okay? You want to have a physical assessment of them. You want to make sure if there are any signs and symptoms of diseases that you can know about. You can pick it up so you'll know what complications might occur. This is for anybody, no matter how old they are, whether they're well or whether they're debilitated. We need to have a physical. What are their baseline vital signs? If they have an infection, you want to postpone surgery unless it's an emergency situation. Okay? If they could die without the surgery in spite of the infection, you're going to go ahead and do the surgery. So you want to know about that. Are they anxious? If someone tells you, I just know I'm going to die if I have surgery, would you want to operate on them? No. There may be absolutely no basis for that fear. But that anxiety, that psychological fear that they've got, could put them at real risk. They could die during the surgery just because they think they would. So you would want to do a lot of pre-op teaching and explore some other alternatives.
And I have told the surgeon about the patient saying that, and they have stopped the surgery.
Mm-hmm.
So it is that, because it's a self-fulfilling prophecy, and there's a lot of issues with what you believe and what will happen, and stress increases your corticosteroids,
Mhm.
which decreases their immune system. So who knows? They may do it 2 days later after they have calmed down and or whatever. But I know there have been cases that the surgery did not take place that day.
I have too. It's a real thing. How healthy were they before? What chronic illnesses do they have? If you've got someone who has, say, congestive obstructive pulmonary disease, they're not going to want to do general anesthetic on them if they can avoid it. They're going to try to do some other type of anesthesia to get the same result. You want to decrease post-op complications. The nurse is very proactive. They're the client advocate. As Dr. Bixler said, she told the doctor that the client had said this. She was the patient advocate. She was the client advocate. That's what your role as a nurse is. Sometimes the physicians come swooping into the room and they're there for as long as their schedule will dictate, and they'll swoop back out and the client goes, oh, I wanted to tell him or her this, and they forgot because they were just so rattled or they were just so nervous or whatever. The nurse has to then go back and talk to the doctor about that and say, you know, doc, they wanted to tell you about this, and can you come back and talk to him again? The docs will do that because they don't want to risk complications in the post-op period any more than the nurse does. But they need to be told. Okay?
I think one thing that is really good is for you guys to be in the room when the doctor is there, so you have an idea of what they're talking about. If the patient early on has told you that he is constipated, but he doesn't tell the doctor, you can say, Mr. Smith, didn't you tell me that? Whatever. Also, you can explain what the doctor says, because they may not really understand, or they were so anxious that they really did not hear the doctor. So to me, it's a great idea for you to go with the doc and see what he is doing.
And most of them will let you. Most of them will let you.
Oh, yeah. And they will teach
Mm-hmm.
at that point.
Doctors love to teach for the most part. And you're just little sponges waiting to absorb it all. And they just think that's so cool. Most of them. Okay. Continuing with the assessment, you need to know their cardiovascular system. You need to know their respiratory system. Now, I'm not going to go a lot into this because you've had assessment. You know what the problems are. And I want you to read your book, too. Novel Idea. Who's opened it? I love you guys. This is great. Now, when you opened it, did you read it? Okay, I've got 2 that admit they read it. 3, 4, a few more. Excellent. Excellent. Okay. When you're thinking about the renal system, the genitourinary system, kidneys are really, really important. Okay? And they control so much with fluid and electrolytes, with acid-base balance. And if they are not working properly, they can throw the fluid and electrolytes off in the post-op period and can set your client up for more complications. Another thing is the drugs don't metabolize right. We can't excrete them properly, and so they build up in the blood system and will have possibly some adverse effects that we didn't expect. Okay? Anybody know what Plavix is? It's going to keep your platelets from aggregating, okay? How often do you give it? Do you know? It's usually once a day. For most people, it's once a day. My dad takes it every 3 days. We cannot give it to him any more often than that because guess what doesn't function so well for a 96-year-old? The kidneys. So, any dysuria, any nocturia, these are going to be clues that they might have some problems in the post-op period peeing. Do we want them not to be able to void? No. Okay? So we need to know about this ahead of time. What's their usual fluid intake? We're probably going to want to encourage more because none of us drink as much as we should. Water, I mean. Neuromuscular. If your client is mentally impaired, okay, you need to know what is their baseline. Because during the post-op period, you might be thinking, uh-oh, they've had a stroke or something, or they've had some sort of mental change because of the surgery, and this could be normal for them. Or they could have deteriorated because of the surgery, because of the trauma, because of the stress. You need to know what is normal because you want to get that client back to normal, or better than normal if possible. Are they at risk for falls? My 96-year-old dad is. He sure is. You got to watch him like a hawk. Dad, take your horse. He's got a walker. We call it his horse. So giddy up. He gets it. Off we go. It's so cute. Y'all would love it. Deformities. If they have any deformities, it could really affect positioning in the OR. For the most part, when you're in the OR, you are dead to the world. You are unconscious. You do not know what's going on. Guess what we're doing to you? We are positioning you this way, that way, moving you around. If your arm doesn't move like this because your shoulder is fixed, and we get you nice and relaxed, and we go like this, what have we done? Probably caused some injuries. So we need to know, are there any deformities that are going to interfere with positioning? Okay? Shape, length of neck, thorax, all of these things come into play when the anesthesiologist is going to try to intubate if they're doing general surgery. All right, it's all very important. Do they have a prosthesis? One of the things that we use in the OR to stop bleeding is electrocautery. That's one of the things that's going to affect you when you're in there, when you smell it. Because when they start burning who likes to cook out? You won't for a while after that. Because you'll smell that burnt meat smell because they have, I'm sorry, I get very graphic. But I want you to be prepared. But they have to sear, they have to cauterize those cut blood vessels to keep them from oozing and keep them from bleeding. Surgeons don't like blood because it occludes their operative field. They can't see. Okay? In the post-op period, they want people to have their blood circulating and do all the good things. But when they're actually doing the surgery, they want to be able to see, so they want that blood out of the way. So we'll use electrocautery. What you have to do, though, is ground the patient. You have to have a grounding pad that you put somewhere. If you put it on a prosthesis, have you grounded your patient? No. What can happen with that? That arc can go through the patient and cause them to go into cardiac arrest. Because this is electricity we're putting through there. We've got to have a way for it to come back out. We can also start fires. That's a very real problem too. Okay, malnutrition or obesity, these will increase the risks. Okay? You'd think a very, very skinny client would be a good surgical risk? No. If they're malnourished, that can put them more at risk in post-operative periods. Surgery is going to raise the metabolic rate. They're going to decrease their level of potassium. They need more vitamin B and C for healing, for afterwards. So all of these things come into play. And this is all part of what your assessment is. This is your nutritional assessment. Fatty tissue doesn't have good circulation, so it's not going to heal well. You have more problems with wound dehiscence. That's a term that you'll learn to really want to never see. Okay? So a word that you'll fear somewhat because you really don't want someone to dehisce. Because dehiscence is when the wound breaks open. You think it's been healing, but all of a sudden it just pops open. And what can come out when it pops open? Everything that was being held in there. Okay? So they can eviscerate because of the dehiscence. Yes. Psychosocial, you need to do an assessment of that. What's their anxiety level? What's their fear? Did they have a relative who died on the operating table? They could be afraid that's going to happen to them. If they've had someone who, like my mother worked in the OR for years, I had absolutely no fear of surgery because, I'd be bopped in there all the time. Not all the way back into the OR suite, but it was very normal for me to stick my head in and talk to the docs and talk to the anesthesiologist, and I had no fear of it. And that's where I went to work right away. And I love anatomy and physiology. It was so cool seeing the body open like that. But for someone who had someone die on the table, totally different story. Okay, so you got to look at that. What's going on with them? What are their coping mechanisms? They need to have labs and x-rays and things preoperatively so they can look and see. They want to have a chest x-ray so they can find out, is there anything going on in the lungs? My father-in-law found out that he had lung cancer when they were doing a pre-op chest x-ray for prostate surgery. We pick up a lot of things like that, but they need to know, because any problems with the lungs is going to cause problems in the post-op period if you have general anesthetic. You need to know these things. They need to have the potassium well in balance, so they're going to want to do a CBC and electrolyte panel. They want to know what's their hemoglobin and hematocrit, because are they going to have enough hemoglobin to carry the oxygen to the tissues during and post-surgery? All of these things play into it. Is the EKG normal? If it's not, they may cancel the surgery to figure out what's going on. Is the client having an MI because of the stress of the surgery? They want to know beforehand. All of this stuff, yes ma'am? If your potassium is elevated, or even if it's out of whack at all, it can put you at risk for cardiac arrhythmia. And then that can put you at risk for MI. Okay. A potassium is a very, very important electrolyte. All of the things, in the nursing process, what do you do first? You gather data, your assessment, and then what are you going to do? You diagnose and you start planning. So your analysis is your diagnosis phase. And with the analysis, you're building your nursing diagnosis. Then you start your planning. What's your major preoperative nursing diagnosis? Knowledge deficit. Okay? Because not everybody has had multiple surgeries or has had someone who's worked in the operating room or a father or mother who's a surgeon, and they don't have a lot of experience with it. So it's a knowledge deficit because of lack of exposure. Okay? So you have to plan for that. You want to teach them about all these possible things that could occur. You need to teach them about the sights and sounds that they're going to hear. Because even though you may not remember it afterwards, at the time, you're aware of it. You're conscious of it. Okay? All of these things to prevent post-op complications. You have to have informed consent. And what is informed consent? It's a signature page. But it's more than just saying, here, sign this. Say again? They have to know their risks. They have to know, what does the surgeon plan to do? What are the complications that could come about because of it? Okay, they need to know all the ramifications. They also need to know, are there other options available? Is there anything else that we can do to solve this problem? Is this their only option? They need to know all of that. Okay? Mm-hmm.
Information comes from the physician primarily.
That information comes from the physician, exactly right. The physician is responsible for informing the client of all of this. It's your responsibility as a nurse to make sure that the client was informed. All you're really doing is witnessing their signature that they have been informed. Yes, sir. You have to get informed consent before. In an emergency situation, that overrides it. If it's a life-threatening thing, they come in, it's a trauma. We've got to take them to surgery. We have to assume that they would want their life to be saved. Okay? And that overrides it.
You can also call a relative.
You try to call a relative if you can.
And have two nurses listen to the conversation, or two persons listen, so that it isn't your interpretation, somebody else can witness. And one of the things we said to the client is, what are the benefits? Why are you having this? What are the risks? What are the alternatives? Let's see, what is I? What is your intuition, the patient's intuition? Do I need, like somebody says, I'm going to die. And what if we never do this? What if we do this? So this is what sometimes when I do classes for maternity patients, this is what we tell them to ask their doctor.
I like that. I'd never heard that before. I like that.
It's really nice, and it's a way of thinking about it.
So write that down, because that won't be in integrity other than, well, Miriam, you weren't talking into my microphone, so I'll repeat it.
Okay.
B is brains. B is benefits. What are the benefits of the surgery? R is risks. What are the risks that would come about because of the surgery, either from the surgery itself or the anesthesia, because the anesthesiologist also has to do this. A is alternative. Is there any alternative treatment that they could have other than this surgery? Okay. I is intuition. What does the client feel about this? Do they think that it's going to be okay? Do they feel that they could die? Well, then they might want to postpone it for a while. And N is, what if they never do this or they don't do this? What would happen because of it? Do you know the word sequelae? What would be the sequelae of not doing it? What would happen? Okay, what would come about if they didn't? Would they die if they didn't have surgery? Or would they continue living normally, maybe just have a little limp, depending upon what it is that they're talking about. So, brain, B-R-A-I-N, benefits, risks, alternatives, intuition, and never having anything. Yes, ma'am?
They were unconscious, although their family or like two people with them, was saying, I don't want the surgery because, like you said, I've had my sister die on the table. What happens in that kind of situation?
Well, in that type of situation, you would then try to inform them a little bit more. They're going to die without the surgery, if it's that type of an emergency situation.
They have medical power of attorney.
Do they have medical power of attorney? Exactly right.
And ultimately, if the family still says no after everything, then what is the doctor's position? What is he supposed to do with it?
That's one of those ethical questions that starts coming into play. Okay? Because a sister doesn't really have power of attorney over the client. Okay? It would be, in the case of a minor, it would be one of the parents, or if it's a married person, the spouse. Okay? But if you've got someone who is alone, then it's a little tougher. What do you guys think?
Most hospitals have ethical committees, and they will deal with that. We had a patient that refused her C-section. They went to court. They went through the court system because the baby was going to die if she didn't have the C-section. So they went to court for that. We have also had people with Jehovah's Witnesses that the baby needed a transfusion. They have gone to court for that. And they have made the court make the decision. Now, we have had a patient in the psych unit who said, I will not take that medicine because my religion forbids me to take medicine. And they went to court, and the court went for the patient. It was his right, because of religious belief, not to take medicine.
Because right,
it depends on what is going on.
when you look right down here, this last bullet, client's right to refuse treatment. The client has the right to say no. Okay, the client does have the right to say no, to make that decision. That's part of informed consent. I know that's not a good yes and no answer saying we would go ahead and do the surgery or we wouldn't. But if the client can't decide, you try to find, do they have a medical power of attorney with someone? Have they signed have they spoken to anybody about what their wishes would be? And you try to find that out and then make the decision that way.
You will hear us say depends.
A lot.
A lot.
When you come to my office, you'll see that there's a depends hanging on the wall, because a group of students a couple of years ago, they got so tired of hearing Mr. Hutton and I saying, it depends, when they would ask questions that they took a depends and they made it like a purse. They stitched up the sides and they put ruffles on it and they made a little handle for it. And then they filled it with all sorts of candies and goodies and little treats for us and gave it to us. It was cute. So I thought, okay, I got to keep this, so it's hanging on my wall. People come back and say, what? Is that really a depends on your wall? And it's like, yeah, it is. Okay, Client Self-Determination Act. Surgery does not negate a client's advance directives or living will. That's the word I was searching for a while ago, was living will, advance directives, if they've got something written. Surgery doesn't negate that. If someone says they have a DNR order, if they have a cardiac arrest, they don't want heroic actions, that does not say that they can't have surgery. Okay? That doesn't say that you're just going to let them die for whatever. Okay? Yes, ma'am. If it's life-saving, they can, certainly. Yes, even though they have a DNR. Okay? A DNR is referring to CPR, heroic efforts. Surgery is not necessarily a heroic effort, depending upon what it is. What's causing them to be unconscious. Okay. Dietary restrictions are very often put in place before surgery, and this is to prevent complications after surgery. Okay? That's the reason for it. If someone is going to have a general anesthetic, one of the adverse reactions to waking up from these inhaled gases is they get nauseated, they get sick to their stomach, and they will puke. We don't want them to have anything in their stomach. What happens to a person who is unconscious that vomits? They can aspirate. We do not want vomitus in the lungs. It's a bad thing. What's part of the acid? Exactly. The digestive juices that are in the stomach contents will start digesting the lungs. It's not good for gas exchange. So we want them NPO for at least 6 to 8 hours preoperatively. A lot of times we'll have them after midnight. We'll put them NPO after midnight, and that decreases the risk for aspiration. They're regularly scheduled meds. This is always tricky in the hospital because the client may have this long grocery cart list of medications that they take. They take a vitamin, they take an aspirin, they take medication for their blood pressure, they take a medication for their lipids, they take, all this stuff. But they're supposed to be NPO after midnight. How do we give them their medications? And do we need to give them their medications? Their aspirin should have been stopped beforehand because we don't want to increase their risk of bleeding. But what about their blood pressure medication? A small sip of water. Very often you'll ask the doctor, in fact all the time, you'll ask the physician and the anesthesiologist, which ones do you want them to have? Do you want us to hold all their medications? Do you want us to give something by a different route? There are some medications you can give IV and get a good benefit with them. And you're going to learn how to give IV meds shortly. Okay? So we may give it by an alternate route, or they may want it held. Diabetics, if they're normally taking an oral agent, they may want them to have insulin instead. Because, you haven't studied this yet, but stress increases your blood glucose level. Even if you are NPO, if you are not eating anything, and what does NPO stand for? Nothing per aura. Nothing by mouth. That's your aura. Okay? Nothing by mouth. Even if you're not eating, their blood sugar can still be elevated because of the stress, and it can be elevated quite high. Someone who has an elevated blood sugar is going to have complications after surgery. Okay? So, we'll very often give them insulin, whether it be sub-Q, that's our usual route that we would use, or whether they opt to give them a little bit IV. Okay? But they'll usually have their insulin. GI and skin prep. Used to, everybody going to the operating room, we did like a full body shave. Not really, but it seemed to be. Abdominal surgery, we shaved from nipple line all the way down to groin. Okay? Even if they were having a little appendectomy, it was nipple line down to groin. Everything was shaved. And growing back, itch, painful, hurt, all these things, we found that this was not the best way to do it. What happens when you shave something? You're irritating it. You're breaking the skin barrier. You're putting them more at risk for infection. And you also stir up all the normal flora that live on our skin or in our body itself. We actually have, normal organisms that live and are helpful for us. We don't want them inside the body. We want to remove it before surgery. So now we'll do skin prep, like betadine. There's a little picture of betadine. Or Hibiclens is another one that we use quite often. It's chlorhexidine is the generic name. And we'll have them take a bath or a shower the night before surgery to help cut down on that normal flora. Then when we get them into the OR suite, we'll clip the hair in the area that's going to be operated on. We don't like to use razors anymore because of that abrading, that causing damage to the normal skin. Okay? And we'll do a betadine prep there in the OR. You need to let the client know that they could have tubes when they come out, depending upon what their surgery was. What's the purpose of those tubes for that drainage? And what might it look like if they're going to have a Foley catheter? Sometimes you don't know whether they're going to have this or not, so you need to let them know about the possibility. You could have this. IVs, any medications and things, you want to try to give them advanced warning about it, just in case it might happen. But you want to give the information in such a way that you don't scare them. That can be tricky. They need to know all of the, no, that's for you. You need to read everything that's in there about pre-op teaching in your book. Main things that you need to teach them about is the importance of breathing, the turn, cough, deep breathing, to try to get the alveoli open, to try to blow off all the anesthetic gases that they have taken in during their surgery. Incentive spirometry is a really great thing. Back in the olden days, we would have people like blow up balloons, or we would have straws that we would put into bottles with water in the bottom of it and have it blow so that they would blow bubbles. Well, the incentive spirometer uses the reverse. It's bringing air in and having them improve their lung expansion. Like blowing balloons and blowing bubbles into a water bottle is blowing out. It's not necessarily taking in a deep breath, and what we want them to do is take in more. So the incentive spirometer will let them see how big a breath they're taking, and we can encourage them, oh, you can go a little bit more, come on, a little bit higher, a little higher. And you have a little goal that you want them to reach. You can put a little mark on it and say, okay, let's do more this next time. That really gets them to expand their lungs even more, helps prevent those complications. You need to teach them how to splint, because if they've had abdominal surgery especially, it hurts like the dickens to cough. And you have to cough, because when you cough, you're expanding those alveoli. You're sort of shaking them up. You're also mobilizing any secretions that are in there to help the client prevent any complications. How do you splint? You can give them a pillow. Put it under their head? No. They've got to hold it over their incision. Sometimes a pillow is a little too puffy and they can't get enough support on the incision. I like to have people lace their hands and put their hands directly, or using like a bath blanket, something that's a little smaller, right over the incision, and then putting gentle pressure, and then coughing. Okay. That's the picture of an incentive spirometer. For the legs, you learned on Wednesday about sequential compression devices. Those are to help prevent deep vein thrombosis. As you lay flat for a while, the blood pools. It's going to be more at risk for clotting and causing thrombosis. You don't want that occurring, so you use either TEDs or SCD, sequential compression devices, which is a type of pneumatic compression. Plexipulse is another brand. You also want to teach clients about range of motion, about moving their legs when they're in bed, doing all sorts of things. You learned about passive range of motion as well already. Sometimes you need to assist the client with that. That will also help prevent deep vein thrombosis and pulmonary embolism. Mainly, we want to get them up. The night of surgery, we're probably going to be dangling them at the bedside. We may not make them walk the first day, but we're certainly going to dangle them so that we're starting to mobilize them and get them move around. But the next day, we want them up. And they're going to say, I can't, I hurt too much. Go away. No, you got to get up. This is when the nurse gets really mean. And they hate you. Do it anyway. They'll hate you more if they get pneumonia. Okay? Get them up. Get them moving. Turn them. This is this is a picture of the sequential compression devices, just a different type. What do you do about the anxiety? Let them express themselves. Let them tell you why are they so anxious? What maybe has occurred in the background. So get them talking about it. Okay? And maybe you can help overcome that anxiety. You want them to be able to verbalize that anxiety, and you want to teach them how to relax. How can you teach someone to relax? Some deep breathing exercises. What about visualization? Guided imagery is another wonderful thing for anxiety and relaxation. Okay, it's a little more advanced nursing skill, but it's something that you can certainly start practicing with your clients. It's not difficult. Give them the facts. Give them, assess what they know, and then correct any information that they might have is wrong. Okay? Give them time to ask questions, just like I'm going to let you. Yes. And even if you haven't had it, you can say, you know, most patients who have had this this is what we see happen. Okay? Building a trusting relationship is very important. What's the term that we use for that type of relationship? What are you trying to develop with your client? Therapeutic communication, but rapport. Okay? You want to develop rapport with your client. So they feel that you're approachable. They can ask you anything and you'll give them an honest answer. Okay? So it's a trusting relationship for communication. You want to promote rest. If they're anxious, they're not going to be able to sleep. If they're sleep deprived, they're not going to have a good result. So you want to promote rest. A sedative is often prescribed, but it's usually not necessary if you can do some of the other things that can help the client, like a back rub. A back rub or a foot rub is just so soothing and so relaxing for most patients. And not just preoperatively, but postoperatively as well. I fussed at all my Adult Health 2 students last semester because nobody was offering back rubs. They were twiddling their thumbs. They'd say, "Did you give your patient a back rub?" "No, they didn't ask for it." I don't care if they didn't ask. You offer. That's part of your good patient care. Okay? It's very soothing. It really develops rapport. Distraction, music, TV, reading, visiting. What do they normally do to help themselves relax? If they normally watch ER, I don't know, the night before surgery, that might be a bit much. But, you know, Grey's Anatomy, that's the one that everybody's watching now. I don't know. You want to teach the family and the significant others as well. It's not a one-person show. You include them in your teaching as much as you can. Okay? You need to let them know. How long do you think this surgery is going to be? You can give them guidelines. You don't know for sure, but generally it's around this long in the pre-op area, this long in surgery, this long in post-op. The physician will contact you. You can wait over here in this other area. Come on. What's going on? Okay. When you're looking at the chart and you're going through it, if you see anything that sends off a red flag to you that might be of special import for the surgeon or the anesthesiologist, if you don't know if they've seen it or not, you need to notify them. For example, the client has a hearing aid or a hearing problem, so they use hearing aids. How would that affect their care? If it got lost, they might understand, because don't we ordinarily take everything off the client when they go to the OR? Because we don't want them to lose. We don't want to be responsible for losing things. So now you've got a deaf client or someone who has difficulty hearing, and you're saying, "Would you roll over now?" And they can't hear you. So you're going to have to find out how can you best communicate with them. These are things that the surgeon and the anesthesiologist definitely need to know. Any special concerns or instructions that they have. Their Jehovah's Witness. If they have any advanced directives. These are all important to make sure that everybody knows. There's a preoperative checklist, and I believe there's a copy of one in your book that has all of these things, so you can go through them and make sure that everything is there. Usually they're going to wear a gown. A lot of times we can allow them to keep their underwear, depending upon what's going on, until they're in the OR, and then we'll remove it. Okay? If that's very important for them. Valuables, we want them at home. We don't want to be responsible to them. If they have never taken their wedding ring off and they really don't want to take it off and their fingers are swollen, is a bad thing. If they normally just don't take it off, we can tape it on to make sure. We wouldn't want their finger to become so swollen that it would obstruct their circulation. So we would really want to try to do something about that one. We want to have the valuables at home with the family is preferred. Do they have their ID band on? Any allergies noted on that so that everybody will be aware of what's going on? If they've been typed and cross-matched for blood, is that band on? Okay, because we want to make sure if we have to give them a blood transfusion that we give them the correct blood transfusion, that we're not going to have any problems or complications with it. Are their dentures out? A lot of times an anesthesiologist will say they want the dentures in because it will affect how they put the endotracheal tube in. So if they want them in, you would want to leave them in. But they might want you to send a cup so they can take it out right at the end. But you need to know that. Oftentimes the dentures are out. Prosthetics, on or off, you need to know about this. Hairpins, you don't want them in. Because what if they had a hairpin and we positioned them on the table and that hairpin is poking into their head and they're asleep and they can't tell us? We're setting them up for what? A pressure ulcer, some sort of damage there. We talked about hearing aids. Nail polish. What if you have somebody coming in with blue nail polish? That's right, you can't read it. You got to get at least one fingernail clean. We don't have to take all of it off, but they have to have at least one fingernail clean so that they can check for cyanosis, they can put the O2 sat oximeter on. Empty their bladder before they go. That's all part of the pre-op checklist. Preoperatively, they may have them take a sedative if they're very, very anxious. Usually they don't. They'll usually go ahead and take them into the pre-op area, and then they'll give them medication back there. Very often you'll see them having antibiotics that they'll want sent with the client, and when they're in the pre-op holding area, they'll give it to them because they're starting to do, the research is showing that if they put a loading dose of an antibiotic on, they're having less postoperative infections. The chart is sent with the patient along with, used to we would use the printed off MAR. Now with the EMARs, I'm not sure how they're quite doing that because the OR has access to the same thing and they can see the EMAR as well. Stickers, used to we would have the addressograph that we would send with it. I'm not sure quite what the hospitals are doing now. The policies change a little bit as technology changes. If it's an ortho patient and they've been in traction of some sort, we'll take them in the bed. Okay, because we don't want to disrupt that any more than we have to. So we'll transport them to the OR in that bed with that traction set up. And then we'll move them over to the OR table. If it's an ambulatory setting, the patient will actually walk from the pre-op holding area into the OR. When I had my blepharoplasty done, and yes, I've had one done in Brazil, it was pretty cool. It was all in Portuguese, naturally, and I'm having this conversation as we're just strolling on in and hop up on the table. Here we go. Okay, the next step in, yes ma'am. If they've had a broken leg and they're going to be going to the OR, oftentimes they'll have to put them into a device that will pull the fracture, keep it in alignment. I'm thinking specifically of someone who's, little old ladies who break their femurs. It will shorten, the muscle will cause it to shorten and will cause pain and deformity. And so they'll put them in a traction that will pull the leg down and keep it straight. So we want to keep them in that. That's just one example. Okay? The next step in the nursing process is always evaluation. Was your teaching effective? Do you need to redo anything? Did they understand? How do you know if they understood? Have them repeat back. Have them show you. Okay, have them show you. All right, we're going to take a short break. All right, we are tegratized. Okay. We are now into the operating room, which is an area near and dear to my heart. Now, I believe you guys learned how to put on masks and gloves and all of those things. Did you learn a surgical scrub? You watched it? Standing there like this, doing your fingertips after you cleaned them with the under the nail brush, or orange stick is what we called it. And then the other fingertips, and then all the surfaces, and you did that for like 20 minutes. Felt like it anyway. You know, the one thing on the television that is so wrong, all those doctor shows, they're standing there, they've got gowns on, and they're at the scrub sinks, and they're scrubbing away, and they're talking to everybody, and they don't have a mask on. Ever. And they're scrubbing, and it looks so cool, and then they go in like this, and the nurse ties the mask. Wrong. Your mask needs to be on when you're scrubbing, because you're talking. What are you doing? Germs are coming right out of your mouth directly onto your wet hands. So, that's just wrong. I just want to let you know that. Okay. Your client is in the OR. They are at risk for all sorts of stuff. They're at risk for infection because we're cutting into their main line of defense, their primary barrier. We are impairing their skin integrity. We are increasing their anxiety because, we're cutting on them. We're making them unconscious. They don't know what we're doing to them at that time. That's sort of an anxious time. You give up control. Altered body temp. Those of you who have been to the OR, what was the temperature? Freezing cold. It has to be freezing cold because we're trying to cut down the growth of organisms, but we're also making it comfortable for the surgeon and the assistants sitting or standing around the client's open body underneath the hot lights that we've got directed into the body cavity with all the gowns and the gloves. And you get hot underneath those. So the OR is cool for a couple of different reasons, but that can affect the client. And we are definitely causing injury. We're trying to improve their outcome, but we are hurting them to begin with. AORN is the Association of Operating Room Nurses, and it has developed standards of care. Okay? Nursing care is critical to protect the client during this time period. The client is totally dependent upon the nurse. If we're putting them under general anesthesia, they cannot do anything for themselves. If the anesthesiologist paralyzes them, they cannot even breathe on their own. I thought, what? I didn't have that on my slide. Okay. Anyhow, the client is totally dependent upon the nurse for everything. For safety, for comfort, for dignity, for physical, for spiritual needs, psychological needs. We position people on the operating room table. Their arms, normally your arm has muscle tension in it, right? And you can control where your arm is. If you're laying in bed and your arm goes to sleep, anybody ever laid on it and your arm's gone to sleep and it feels real funky, but you can't lift it up, right? Imagine these people in the operating room. We move them over to the table. We move them around. They have no control over their bodies. Their arms can flop off. Their legs can fall down. We cause damage. We can cause injury if we are not diligent at all times to watch what we are doing. If we have a client, we've tucked their arms in at the table, or even if we've got it on an arm board, and it's covered up, you don't see it, you don't want to come over and lean on it, because now you're putting pressure on the client, and they can't tell you, hey, you're on my arm. You have to be diligent at all times. They cannot protect themselves. Okay? Members of the surgical team, you've got the doctor, the surgeon. You normally have a surgical assistant, or oftentimes you have a surgical assistant that will be there. You may have the anesthesiologist or a certified registered nurse anesthetist, CRNA. Okay? They are nurses that are specially trained to, as my anesthesiologist friend says, pass gas. He also tells me that they are, more importantly, they're not the people that put you to sleep, they're the people that wake you up, which is more important than putting you to sleep. And it's like, okay, minor discrepancy or difference, but yeah, okay, I accept that. Often they have an anesthesia tech who will assist with preparing their things, making sure they've got all of the medications there, that their laryngoscopes are clean and sterile, because you wouldn't want the same laryngoscope that was used on the first patient used on you when they're putting an ET tube in. Perioperative staff is going to include a circulating nurse and possibly the scrub nurse. Sometimes the scrub nurse is the surgical assistant. Okay, let me see what the next slide is. Okay, you have the holding area nurse, which is like a pre-op nurse, bringing them into the OR, your circulating nurse, the scrub nurse or the surgical tech, and you may have a specialty nurse, someone who is functioning just for that specialty area. It could be someone who knows more about the laser, or who is responsible for making sure that there are safety shields on if someone is doing laser surgery, or that they have door signs on warning people. So they're going to have some other responsibilities. To me, the most important person in that room, other than the patient, is the circulating nurse. The reason being, the circulating nurse is the manager. She has to be responsible for all of that. Okay? A scrub nurse can be an LVN. A circulating nurse can only be a registered nurse. That's why I say he or she is the most important person in that room. Okay? That's required by law, I believe. Okay. I don't remember what the acronym is. As I told you, I didn't make this slide, so I'm not sure. Check your book. If you find out, please let me know. Okay. The surgical suite is it's very important that it's prepped properly. One of the first things that I had to do when I would go into the OR every morning, and it wasn't just me, it was all the other nurses too that would go in, we had to wipe down every horizontal surface in that room. Because although they were terminally clean the night before, overnight microorganisms and dust and whatnot could settle down on the horizontal surfaces. So we had to use alcohol and wipe down everything. My table, the surfaces that the anesthesiologist was going to have their stuff on, my overbed table where I would be putting my trays, called a Mayo tray. I would have to wipe down the area where I was going to be working if I was a circulator. Every horizontal surface had to be cleansed again that morning before we started. Even though the operative areas were going to be covered with sterile drapes to prevent, we just wanted to make sure that it was a clean area to help protect the client. because of all the things we were about to do to them. We want to minimize any risk. You do this by, as I was cleaning and whatnot, another thing that we do is limiting the traffic. Because the more traffic, the more people you have coming in and out, the more germs you're bringing in and out. As you walk along the floor, even though we mop the floor and they use germicidal solutions cleansing the floor, walking along, you increase movement, air movement, and that will move those germs. People going into the OR, we used to keep our shoes in the OR, and you would have street shoes that you would change into. Now I believe most places have booties that you put on, and you can throw them away as you go out and come back in. Again, this is all to try to cut down on the germs. We put the client on the bed, the OR bed, and the first thing we're going to do is strap them on it because we don't want them falling off. They can't protect themselves. This is us trying to protect them. You can't really have bed rails that you pull up on an operating room table because you have to be able to get up close and personal to the person. You've got to be able to get in to do the operation, whatever it might be. The beds have to be locked. Okay? When you're moving a client from the gurney or their bed that they've transported them in with, you have to lock it. The OR table has to be locked because as you're moving them from one table to the other, if the bed weren't locked, it could slide out, and where does the patient go? On the floor. Okay? All of these things are safety issues that we're thinking about to protect the patient. If it's very, very cold in the room and we want to try to keep the patient, if they're going to have a long surgery, we want to keep them from losing too much body heat, we may put a heating pad on the table, a special type of heating pad to help preserve their body heat. If there are areas that there are going to be restricted movement for quite some time, we might need to pad the area. Any bony parts, any nerves, we're trying to protect them from damage because the client cannot do this themselves. Okay. I found this picture yesterday and I thought, well, okay, that is pretty descriptive, showing you what someone in the OR looks like. Okay? This client has an endotracheal, sorry. Boy, I went a ways, didn't I? This client has an endotracheal tube in. He's fully paralyzed or asleep. He cannot breathe for himself, so he's attached here to the respirator. This is the anesthesiologist or the nurse anesthetist who is monitoring that to make sure that he's being fully oxygenated, that he's watching what's going on, that he's breathing sufficiently. Look at this client's arm. That client's probably going to have some nerve damage here, depending upon how long this arm has been hanging off like this. That's not a natural position. Okay? He can't tell him, hey guys, my arm's hanging off the table. You as a nurse need to watch for that. You have to make sure that the equipment is working properly. If you're using that electrocautery, you need to make sure that you have the client grounded. You want to make sure that all the instruments have been sterilized. Sometimes we have to use the same instruments over and over and over again through several different cases. Well, you wouldn't want to use the same instruments from one operation to the next unless they were sterilized. And very often it's the circulating nurse that's running those instruments out, cleaning them very quickly, putting them in the flash autoclave to kill all of the germs, and then running them back to the next operation. Okay? Maintaining sterilization, all to protect the patient. You have to do a count of all your instruments and all of your sponges and all of your needles to make sure that nothing was left inside the patient. All the sponges that are in the operating room should have a radiopaque strip through them so that if we have the wrong count, they can do an x-ray and see where is it. They are not supposed to stitch up. They are not supposed to close if the count is incorrect. It's very, very important. You'll have sponges. I used to hate some of the long operations because my sponge bucket, and I'd have this one surgeon who would throw it in the wrong sponge bucket. I've counted that already. Don't put that there. To move it over here, and you have to keep count and know exactly how many you have, because they're not supposed to close until you tell them, oh, count's right. Same thing with needles. You'll see special magnetic pads that they put the needles on. You keep count. How many did you give them? So you know how many you should have at the end. Because you don't want anything stitched up into the client. The client can't tell you, hey, you forgot something in there. The layout of the hospital, of the OR suite, is usually out of the mainstream of the hospital. You don't want visitors getting confused and wandering in off the street. You're trying to cut down on germs to protect the client. You're also trying to protect the client's privacy. That's another thing that you have to be aware of there. It's going to be areas that are easily divided between what's clean and what's contaminated. Once you've had instruments that you've used, they're contaminated. They have to go into the area to be processed, to be cleansed, to be sterilized, to be packaged properly so they can be used again. Those areas need to be separate. If you have a case that is going to be potentially infected, you wouldn't want to have that case done in the same room that you do open heart surgery. Okay? So they're going to have an area where they would use for those potentially infectious cases. And they would do those at the end of the day after they finished with everything else. There are areas that are designated as unrestricted, where anybody can go in. When I was a little girl and I would run in to see my mom, I would go into the unrestricted area. I was not allowed to pass into the semi-restricted because I was not wearing the appropriate clothes. I still had on street clothes. Okay? And then the restricted zones, which are the sterile areas where you can only go if you're properly attired and garbed, you have on your mask, you have on your head covers. Okay. There are staff lockers, rooms, lounges where you can go to relax a little bit, where they'll change clothes. OR should have scrubs, in my opinion, that have been laundered at the hospital. OR staff should not be allowed to wear their scrubs in from home that they have laundered, because they're passing from home to the OR through areas that are full of germs. So they're bringing those germs into that OR suite. Okay, and I believe this is one of the AORN standards. The hospital should provide the scrubs. You come in your clothes, you change into your scrubs, you take those scrubs off and leave them there when you go home. All to cut down on germs. You need a reliable communication system going on as well. Skin, hair, respiratory tract, as I said, we've got organisms all over us. We have to keep our organisms away from the client. So we use masks, gloves, gowns, head covers. Every bit of hair is covered, including facial hair. But other than that, if you've got an open wound, if you've got a cold or some type of infection, you're not going to be working in the OR. You may be working in the contaminated area for a while until you're over that, whatever it is, before you're able to go back into the OR suite. You don't want to have any communicable diseases. You don't want to share those germs with others, okay? Trying to protect the patient. Hand washing between cases. Normally, the suggestion is that you bathe or shower shortly before you come to work. The reason being, just like we had the client take a bath or a shower to cut down on the organisms, you're going to cut down on the organisms that you bring into the OR suite. You don't wear jewelry. You don't want to have microorganisms that can lodge underneath your jewelry. Okay, so you just don't wear it. And They'll do periodic cultures of the hands. They'll also do nasal cultures to check and see. Anybody have any organisms that are colonizing? Clean scrubs at the hospital, not at home. Cover the hair. Mask if you're going into the sterile area. And if you're at the OR table, if you are the scrub nurse, you're wearing a sterile gown. If you're the physician, the surgeon, you're wearing a sterile gown. Okay. And it gets so cold in there. The anesthesiologist or the nurse anesthetist, the circulator nurse, those who are not wearing the sterile attire will usually have jackets on, and they're like scrub jackets. Again, that should be provided by the hospital to try to keep you warm. To do the surgical scrub, you guys said you saw it. You knew they took their jewelry off. They had the mask on. They scrubbed 3 to 5 minutes, fingertips to elbows. The first scrub of the morning was always longer. 3 to 5 minutes was in between cases for your second, third, fourth, fifth, however many times you did it. Hands were dried with a sterile towel in the OR. Okay, you would go dripping like this, not like this, because you want the water to run down from clean to dirty. Because your hands aren't sterile. You could never sterilize your hands unless you chopped them off and put them in the autoclave. Not good. Okay? So, not sterile, just clean. Walk in, use a sterile glove, pat, 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 drop the towel, put on the sterile gown without letting your hands poke through, and then don the sterile gloves. Pray you stay sterile. Y'all know what that means? Keep your hands like this. Keep them together. Okay? If your hands are together and up, you're not going to touch anything that's below your waist, because below your waist, it's not sterile. Okay? So you keep them up like this. General anesthesia, I want you to really study this part in your book. I want you to look at the different types of anesthesia. I want you to be aware of more of it when you go to the OR, and because you'll probably be standing beside the anesthesiologist or the nurse anesthetist. I want you to have a little idea of what they're doing. Okay? There are different stages of anesthesia as they go through the induction. Most anesthesia is going to be inhalation. It's very controllable. They use a mix of inhaled gases, nitrous oxide being one of them, halothane being another one that they use. The client inhales these anesthetic gases. They're volatile liquids. And you have to assist their respirations. They'll use an EP tube. They'll put down an endotracheal tube, and the physician or the anesthesiologist, the CRNA, has to breathe for the client when they have them paralyzed. Okay? They'll usually put them on a mechanical ventilator unless it's going to be a very short case, because the anesthesiologist and the nurse anesthetist don't want to sit there and bag them the whole time having to breathe for them. Their hands get tired. Do the other one for a while. So they'll put them on the mechanical ventilator. Nitrous oxide, as I said, is one of the inhalation gases. It's usually odorless. You don't really see it. It has a bit of a sweet smell. It is non-irritating. As they start to wake up, they start shivering, and they'll actually wake up fairly quickly. And so they're watching for any side effects that might occur. IV general anesthetic, they'll use an IV drug to put them asleep very quickly, and then they'll have them breathe the anesthetic gases afterwards. They might not really know they've had gas. They thought they just had the IV. You've heard about truth serum? That's sodium pentothal. And that's what they would use very often to initiate the anesthesia. They would inject some of the sodium pentothal, and the client would go to sleep. Now they would use the gases. They would put them to sleep like this, and they would use maybe some succinylcholine, which is one of the drugs to paralyze them, put down the endotracheal tube, and then they'll start using the anesthetic gases. Okay? The client doesn't usually know. One thing that you can teach a client about the pentothal is they might taste garlic in their mouth when they do the injection. Some people will tell you about that. Ketamine is another drug that they'll use for this IV induction. It puts them more like in a trance-like state, but they can get very agitated when they're coming out from it, and so they need to make sure that the rails are padded, that they're suctioning there, because they'll start salivating a little bit more. Propofol. Do you remember Michael Jackson? This should be used in the anesthesia department, not in your home. The bad thing. Enough said, we'll go on. Okay, they use all sorts of different medications to enhance the anesthesia so they can use less of the inhaled gases. Okay, they'll use Versed, Ativan, Valium, all of these things, and they can use this for conscious sedation. Years ago when I worked there in the OR, we had, they were just starting to do a lot of the, let's see, what's the correct term? Boob jobs, augmentations. And, no, I didn't have one. But I did have blepharoplasty, I told you that, but not at that time. But the surgeon that we had used Valium a lot when he would do anesthetic for the clients. He would use lidocaine. He would use local anesthetic for the surgery. But when he... Let me pause that 1 second. Integrity looks like it's still going. Okay. I don't know. Okay, anyhow, he would use a lot of Valium before he would inject the lidocaine into the breast. Have you ever seen a spinal needle? They feel like they're about that long. They're really only about that long, more or less. But that's what the doctor would use to inject the lidocaine into the breast for doing these augmentations. That's still what they're doing a lot of? Yeah. Yeah. Exactly. I know, it just blows my mind when I see that. It's like, oh. Anyhow, the Valium, you have to be very careful how you're using it. The physician may want you to inject it very quickly. The point of this story is you need to know what is the safe rate of injection of a medication. And even if the physician tells you, no, give it faster, it's your license on the line, not his, if you inject it too fast and the client has a bad effect. Know the rate of injection or administration for your medications. Lots of other medications that they'll use, opioid analgesics as well, all to try to get the right degree of anesthesia, analgesia for your client. What's the difference between anesthesia and analgesia? Analgesia is pain relief. Anesthesia is what? Not always sedation. No feeling. Okay, you lose the sensation. Okay? Sometimes you can lose movement as well. Yes, ma'am. I believe so. Years ago when it was developed, it wasn't, but now it's on the street, and I think maybe so. I'm not real familiar with the street names and a lot of the street drugs. I sort of live in a little Pollyanna world where those things don't exist. Neuromuscular blockers, they use those so that they can relax the client's body so that they can do a smooth endotracheal induction or intubation. They'll also do it for overall relaxation. If the muscles are very, very tense, the surgeon can't cut easily, can't operate easily. These neuromuscular blockers can also alter respiration, so they have to be very careful with that. There are different types. There's a non-depolarizing called, one of them example is Pagulon. Its antidote is neostigmine or atropine. Then succinylcholine is the one and arnectine. This is the one I saw used mostly back in the olden days. I haven't been working in the OR in quite a number of years, so I'm not sure which one is more common now. They have to be careful using arnectine or succinylcholine if your client has glaucoma, because it would raise the intraocular pressure. Balanced anesthesia is when they use both IV and inhaled agents. Okay, it gives it a very, very nice, smooth induction. It's generally safe. It's controlled. It's good for the patient, good for the surgeon, good for the anesthesiologist. It's a nice, nice way to have anesthesia. Okay, at this point in time, I was going to stop this and put on this really, really cute thing on YouTube that I want to show you. But I can't, because I can't change from one thing to the other without totally stopping this. I'm going to show you these at the end. So, remind me to do the laryngospasms. Complications, I talked a little bit about some of the things that can be done, but complications can be very minor, like sore throat, all the way to death. Those people who are anxious and afraid they might die on the operating table might have something to be concerned about, because death is a complication. It can occur. Surgery is now done on much sicker clients, but anesthesia-related deaths have been declining for the past 30 years. As they've done more research, they've perfected techniques, they've perfected or come up with new medications. We have much fewer complications, or many fewer complications. It's pretty good overall. Let's go on. Malignant hyperthermia is that one of those complications I was telling you that the anesthesiologists really don't want to have anything to do with. It's a genetic problem that can come on. It's triggered by the inhaled gas and the succinylcholine or the anectine that they use for the paralyzing. The client has severe fatigue, or it can be triggered, by severe fatigue, by strenuous exercise, trauma, which we're doing to the client, emotional stress, muscle injury. Malignant hyperthermia, what they usually see is in the OR when they use this gas, the client's temperature will start rising and rising and rising and rising, and they can't get it to stop. And the client can die from this. Years ago, I did a research paper on malignant hyperthermia, and I can't right now remember. There it is. Dantrium is the treatment. If they can catch it early enough, they can try to stop it. The fever can get up to 111. Is this conducive to your brain functioning properly later? No. It's definitely not conducive to life. Some of the signs and symptoms that they see other than the fever is dysrhythmias. They'll be watching. Anytime you have a client in the OR, they're going to put them on a cardiac monitor so they can watch. They'll be looking for any dysrhythmias. Muscle rigidity. The BP bottoms out. They get cyanotic. They'll get this skin mottling. And because the kidneys can be affected as well, the urine gets sort of cola-colored. Okay? But the fever is the one that's the pronounced one that you see. They're going to do a close questioning of anybody that says they've had a relative who's died in surgery. What did they die of? They want to find out about this because it's genetic. Okay? Other complications from anesthesia, if they had some sort of pre-existing health problem, it can put them more at risk. If they have COPD, it can put them more at risk. They don't usually have overdoses that cause a death in a surgery. Unrecognized hypoventilation. If the anesthesiologist didn't realize that they weren't getting enough O2, they can have the buildup of CO2, hypoventilation, have damage. When they're doing intubation, they can break the teeth. They can have some problems with the jaw, some trauma. Sore throat is a usual one, very common. Sometimes the lip can be damaged a bit, and it can have swelling for a while afterwards. That goes down. Vocal cord trauma can cause some changes in the quality of the voice. Let's see. I'm not sure, what does that say? Sore throat, complicated by anatomy or tumor. Got it, sorry. If someone had a tumor in the area around the trachea, it would make it difficult for the anesthesiologist to intubate, to put the tube in, and so they could have more complications afterwards. They might have to actually go in and do some surgery to correct it. Okay, another one, the laryngospasms. Local or regional anesthesia. This is where motor function may or may not be affected. If they're doing regional anesthesia, they're only putting one part of the body to sleep, one region. If you've ever had hand surgery, the anesthesiologist may have done a block, a regional block, where he only, or she, only anesthetize or put to sleep that part of your arm. It's very, very nice. The patient's awake. They'll give them some sedatives or something to calm them down a little bit, but they're able to talk to you. They're able to maintain their airway. They're not asleep. But that arm or that region is anesthetized. A problem that can occur is motor function can be affected permanently. They don't want that. They want motor function affected while they're doing surgery, but not permanently. A C-section can be a type of regional anesthesia. Usually with a C-section, they'll do a spinal or an epidural, okay? But again, the patient can be conscious. They will sedate them so they can be more comfortable. It's very important for everyone to remember that the client is awake. They are hearing everything that you're saying. And they will remember. Even if you think they're sedated, they're hearing you. Your conversation should be appropriate for that area. Okay? You shouldn't be telling off-color jokes. You shouldn't be making comments about, boy, that person needs to lose about 150 pounds before we do this. You know? That is not appropriate for the client, for what you're doing. So, watch your words. Local anesthesia is when you're just anesthetizing a very small amount, a very small area. They can either do it topically or by local infiltration, like I was saying the surgeon would do for that breast augmentation, where they would inject lidocaine into the breast. Okay. Topically, they can spray, like if they were going to do an endoscopy, they could have the patient swallow and then they would spray down into the area lidocaine, and it would anesthetize locally just for a small amount of time so they could more easily or more comfortably for the patient put the tube down. Okay, regional anesthesia is what I was talking about a while ago. Field blocks, nerve blocks, where the surgeon will inject into a nerve plexus to anesthetize or put to sleep that area that's innervated by that nerve. They're really cool. Let's see. You want to make sure, and the surgeon or the anesthesiologist is going to be very, very careful that they don't inject into the bloodstream. Okay, because these are drugs that can affect the cardiovascular, affect the heart. Okay, lidocaine is what we use if someone has an arrhythmia. We give them a little amount of lidocaine. Anesthesiologists, when they're doing these nerve blocks, use a lot more, and so it can really affect the heart, like cause it to stop. Spinal and epidurals, these are other types of regional anesthetics. This is what you would use for a C-section because you would get a larger area anesthetized. You'll study more about these in OB also because you'll see physician or surgeons doing this. Oh, when I was talking about the nerve blocks, the anesthesiologists are injecting into a nerve plexus, into a group of nerves, so they want to anesthetize that, and they want to make sure that they don't inject into a vein. They don't want to do intravenous. They don't want it to go into the bloodstream. They want it to bathe in the tissue surrounding the nerve.
And is it always like that, or is that just for the nerve blocks?
That's just for these nerve blocks. Well, they never want to get it into the bloodstream, that type of drug. Okay? This is specifically those anesthetic agents that they're using for. Okay. Complications of local or regional anesthesia, you can have anaphylaxis. What is anaphylaxis? Allergic reaction, severe allergic reaction. Okay, so much so that they have the throat closed, they can't breathe, all the swelling. Okay. Incorrect administration technique, if they did inadvertently get that lidocaine injected into the bloodstream as opposed to into the surrounding tissue, that could cause complications. Systemic absorption. Sometimes no matter, even if they did just infiltrate the medication into the tissue, enough of it gets absorbed into the bloodstream that they'll have some adverse effects. Overdose really doesn't happen very often, thank goodness. Cardiac arrest can occur. A lot of times after they've done a spinal, the client's blood pressure will start falling and their heart rate will drop because of the effects of the medications. And so they can go into cardiac arrest. At the site itself, they can have edema, inflammation, because of some interaction with the medication itself, but later that area could become abscess and could necrose because they had lost blood flow to that site. Conscious sedation is a different thing entirely. Conscious sedation is what we're talking about when we do gastroscopy or some sort of endoscopic examinations. They'll do it under conscious sedation. They use IV medications to sedate the client, to depress the level of consciousness so that they're not necessarily aware of what's going on, but they can still protect their airway. Okay? They can protect their own airway. We do not have to intubate them. They can respond to verbal commands. Slide on over here to the table now. They can do that. They can help you. But they're not aware of the fact that you're hurting them while you're doing whatever it is you're doing. Colonoscopies are done like this. Okay? Bronchoscopies can be done like this. It's rapid for the induction, but also the return of sensation is pretty rapid because the drugs that they use have a very short half-life. Some of the medications actually have retrograde amnesia, so they really don't remember what went on. Okay, not only did they not feel it, they don't remember some of the pre-stuff. I remember when my husband had his scope, as he woke up and the doctor had come in and told him what he found. This is just normal stuff. After 50, you all get this privilege. The doctor comes in and tells him what he had found, and I said, okay, you need to get dressed now so we can go home. They haven't done it. Yes, they did. No, they didn't. He swore up and down he had never had the procedure. He will still swear to this day he's never had that procedure. He doesn't remember. He had some retrograde amnesia. Examples of medications that they use: Versed. Oh, it's a wonderful drug. Valium, Demerol, even morphine they can use for conscious sedation. Especially used for endoscopies. They'll use it in the cardiac cath lab. If they're going to do a fracture reduction that they don't have to open up, they can just sedate the client a little bit and then manually reduce the fracture, put the fracture back into alignment. They can use conscious sedation. An RN can administer this under the doctor's supervision, but they need to have advanced cardiac life support certification. Okay.
What is depressed LOC?
Level of consciousness.
Okay, I should have done
Okay. You have to monitor them during and after the procedure just to make sure, even though it's designed so that they can maintain their own airway, we want to make sure that there's not going to be any pooling of secretions or anything, or that they're getting a little bit too deep into this depressed level of consciousness. We want it to be awake enough that they can do that. We need to monitor their O2 sats. Used to, we wanted everybody to have an ECG monitor, monitoring what was going on with their heart. Some places aren't doing that now. I think it's a better idea that they do. Okay. They take the vital signs frequently, again, to monitor what's going on with the client. Once they wake up, they can go home. They shouldn't be driving, though, for they shouldn't drive right away. They shouldn't make any decisions, important decisions, financial decisions and whatnot for about 24 hours because we've affected how they think. And they might not remember that they sold their house for $2.
Is this what they use whenever you get your wisdom teeth pulled?
It can be.
Okay, but I'm pretty sure that's what
Yep, it can be, but they also used other stuff too. They used lidocaine as well. Yep. They're going to be sleepy, but they're arousable. You want them to go home and go to bed for a while. You don't want them to take anything to eat or drink for a little while just to make sure that they are going to be able to maintain that airway. And if they are asleep, you want them to lay on their side. Why would that be? In case they throw up. But also the drool is going to go out the side as opposed to down the back. Okay, collaborative management, assessment, same kind of things that we talked about before. Making sure you've got the correct ID of the client. You've got the correct client. Making sure that you know what you're going to be doing to this client and everybody agrees. You're going to be doing the correct surgery. You don't want to take someone in for an appendectomy if you're supposed to amputate their leg, or vice versa. Okay, so you want to make sure that you're doing the correct kind of surgery, the correct area. Do they have any allergies? Have they been typed and cross-matched for blood, or do they have their own blood that's been banked, autologous blood bank? And are they dressed appropriately for where we're going to do surgery? Medical record review, do they have any advance directives? If something occurs complication-wise, can we revive them? Can we do CPR? Or do they have a DNR? Okay. Do they have any allergies, any prior complications or reactions to anesthesia? And family member, remember we talked about that. Do they have a latex allergy? We need to know the lab results. Those need to be on the chart so we can review them, so we can see what was their hemoglobin hematocrit when they came in. Okay. We need to report any abnormalities. You want to make sure that there's a history and physical, that they've got the baseline vital signs, and know what their routine medications are. They'll start the IV. They'll clip, usually as opposed to shaving. We don't like to shave anymore. We like to clip. The circulating nurse is there to really give a lot of emotional support and explanations while all of this is going on. You do not leave the client unattended. Okay? You don't strap them down to the bed and walk out of the room. Special considerations for the elderly, for those who have sensory deprivation. Maybe they can't see because without their glasses. I'm blind as a bat without my contact lenses. I mean, I really am. I can't tell who's right here without my contacts. So I would want to have my glasses because it's a very, very scary feeling for me not to be able to see. Same thing if they have problems with the heat. I don't consider myself elderly, but I have problems with heat regulation as well. I usually stay pretty cold. But these are things that are special considerations for the elderly. Again, in the analysis period of the nursing process, you want to look at all of these things and think about what problems would come up. Perioperative positioning injury is a real problem that we want to avoid. Okay, so we want to make sure we position the client properly. Let's see. Talked a little bit about these a while ago. Patting the OR bed, grounding the person properly, moving them on to the bed safely, helping the client get comfortable, making sure the skin is properly prepped, positioning properly for the procedure, maintaining the anatomic alignment so that we don't cause any damage to the client. And then once the client is asleep, we're going to have to reposition for surgery. Impaired skin and tissue integrity, obviously, is going to be a nursing diagnosis because we have to slice into the patient's skin to do surgery. I mean, that's what it is. But we want them to have minimal impairment, and we want them to have no contamination. We want to be able to stitch the skin back together so it'll heal very nicely. You'll see some of these things done. Before they do the initial incision, they're going to put a plastic adhesive drape over the client. Once we've prepped and it's dry, they'll put this plastic drape over and then they'll cut through the drape. And that will limit the amount of bacteria that can migrate into the wound. It's really a cool thing. But you'll get to see that. Skin closure is used to approximate the wound edges so it'll heal more quickly. They can also use stitches to tie off blood vessels that are bleeding as opposed to using the cautery that we talked about. Sutures can also be used to prevent wound contamination. Their stitches are in or sutures are in many different sizes, many different materials, and they're going to decide what type of suture or what size of suture based on where it is that they're suturing and what it is that they want it to do. Okay? Wound closure is usually done in layers. As they cut through the abdominal cavity, what are they cutting into? Skin. What do they cut through next? Subcutaneous fat. Okay? Fascia, muscle. Then they'll be into the abdominal cavity, so they're going to have to cut through the peritoneum. These are all things that they now have to stitch back together. So every layer that they've cut through, they have to put a different layer of stitches in. So you could have, when you ask the doctor, how many stitches did you put in? They're only going to tell you about that top layer. And oftentimes they're going to use staples instead of stitches, which is pretty cool too. Again, sutures, y'all can read about this in a bit. I want to move us along here. I'm taking way too much time. Retention sutures, they can do them in a figure eight, or they can just do a really big stitch to try to hold the skin together. If someone is at risk of dehiscence, they are going to put in retention sutures to try to prevent that from occurring. The physician may irrigate the wound. They may insert a drain. There's a bunch of different post-op dressings that can be used. Some are sprayed on, and they'll use pressure dressings oftentimes depending upon what was done. Then we're going to transfer the client from the OR to the post-anesthesia care unit. Okay? And the nurse has to give report to the nurse that she's turning the client over to. You have to watch for hypoventilation. You want to make sure that there are no events that would contribute to the hypoventilation. You want to continue monitoring, make sure that they're breathing on their own. If they have an airway in their mouth, once they've awakened enough that they can control their airway, they'll start trying to spit it out. At that time, you can help them remove it. Until then, they leave it in. If they are not aware of it, they are not able to control those secretions enough, and you may need to suction. So you're watching for all of this, watching their circulation, watching their rhythms, and recording this continuously. Critical thinking challenge, you've got a 69-year-old homemaker. She's supposed to have a total knee replacement. When questioned about which knee, she responds, I think it's my right knee, but both of them hurt and need to be replaced. I don't care which knee they do today. What would you do? Say what? Talk to the doctor. Look at what she signed that consent for. Okay? Because she should have signed the consent before she came in. Because they usually don't do both on the same day. Okay. I'm going to stop us here for the moment. I know some of you guys have things that you need to go for, and I want to show you IVs before we do that. So I'm going to pause this now. You can watch the videos